Namaste and good afternoon. Welcome to our FB Live series. This is Dr. Srinidhi Chidambaram, and I do hope you have all been well and taking all precautions for COVID safety. At Apollo Hospitals, we always believe that it is important for people to know all about the latest advances in medicine and just how quickly the field of healthcare is moving ahead in innovation and technology. So, today, on the occasion of World Heart Day, we have a very special FB Live session on a very exciting topic: artificial intelligence in cardiac care. AI, or artificial intelligence, the intelligence exhibited by machines, touches almost every part of our lives, including medicine. Artificial intelligence is the ability to make computers or machines learn to solve problems that would otherwise require a lot of human effort. Advances in computing power have made it possible to analyze large amounts of data quickly with consistency and accuracy. The computer system is trained by ingesting and analyzing hundreds and thousands of sets of data of similar readings, and then it becomes experienced at looking at a focused problem. This has enabled healthcare scientists and doctors to apply AI to huge complex data sets in a way that really helps in making the right decisions, diagnosis, and treatment by detecting similar patterns in patient data. It's wonderful that AI based tools are already being used by Apollo hospitals to screen for cardiac risk. And to explain all this in detail, I'm delighted to welcome Dr. Shiv Kumar, Director Cardiac Cath Lab, Chief of Cardiology, and Senior Consultant Cardiology at Apollo Hospitals, Hyderabad. Dr. Shiv Kumar has been in Apollo Hospitals, Hyderabad since 1996. He's also faculty, cardiology, preventive and promotive healthcare at the deemed university recognized by Harvard. Dr. Shiv Kumar completed his MD in internal medicine from the Government Medical College, Jabalpur, and then his DM cardiology from the King George Medical College, Lucknow. He's also a fellow of the Interventional College of Cardiology in the US. Dr. Shiv Kumar has had work experience in interventional cardiology, over 9,000 intervention cardiac procedures, 20,000 angiographies and other procedures like balloon mitral valvuloplasties and pulmonary valvuloplasties. He's an expert in peripheral and renal stenting, pacemaker implants and AICD, cardiac resynchronization, and uterine artery embolization, among other procedures. He's an advisory board member of Asia Pacific for Medtronics, Boston Scientific, and Abbott, and also the president, Telangana State Cardiology Society of India. Welcome, Dr. Shiv Kumar, and thank you so much for joining us on this FB Live session on the occasion of World Heart Day. And over to you to tell us what exactly artificial intelligence is and how it is used in cardiology.
Thank you so much, Dr. Srinidhi. Thanks for the kind words. Right at the outset, I welcome all the viewers on this World Heart Day. Today being really special, I feel this session is going to be relevant to each and every one of you. In next 10 to 15 minutes, we'll discuss the role of artificial intelligence and machine learning in cardiology in general, and specifically a model which we developed at Apollo, which has become a global model and a great successful model, how it can influence and impact each and every citizen, every human being in our country and abroad also. So at the outset, as you said, the role of AI in cardiology. So today, AI and machine learning being a part of the AI, is literally touching the every aspect of human life. So the cardiology is no exception to that. So today, the AI and machine learning in every part of every aspect of cardiology, whether it's a research and development, whether it's a diagnosis, whether it's a therapy, and post-therapy as well, the AI is being used. There are a lot of models being built already, and they are on the way to be built. Few more models which are really going to help. Why do we need this? Somebody may say that why do we require this artificial intelligence? Because the moment we say artificial intelligence, generally a feeling comes that probably some computer is going to help us out or some robot is going to help us out. And everybody, as a human being, we always feel that we are quite knowledgeable enough and we are confident enough. So whatever we give the feed to the computer, that only it can produce. So this is a general belief and general faith all of us do have. So the reason is I strongly believe that in a couple of years, the whole practice, especially for the medical field and medicine, is going to change. The patients are not going to really come the way. By the time the patient comes to a doctor, he will have more than 70% or 80% of his diagnosis being already made, because so many tools will be available, so much of data will be available, so much of sensors will be available, which will be available on wearable devices and as well as on mobile phones itself, that the person will load to a large extent. And this whole bunch of data will be bombarded on the physician. And the physician is supposed to go through the whole data and then quickly response, because one of the problems of medical fraternity, probably that's what the other people feel, is the efficacy and the efficiency of the medical field, which is medical fraternity, to respond. So probably to respond quickly, we have to take the help of artificial intelligence and machine learning, which will probably, and not going into further details also, the regular statistical models which we usually do for any time to event, for any analysis, okay, the regression models, logistic regression models. So all those probably can be supplemented by machine learning, deep learning, and it will help the physician. So again, those who do not like to address the artificial intelligence, probably I would say that it's an assisted intelligence rather than an artificial intelligence. So that was the spectrum of artificial intelligence on cardiology or on the physicians and for the medical fraternity as such. Now, restricting myself, it will be impossible to tell that how many aspects we can use right in the cardiology, right from the angioplasty to in-stent stenosis to heart failures, and to diagnose heart failures, what could be the prediction model for the heart failure, and similarly what could be the length of the stay in the hospital, and a particular type of myocardial infarction, whether that person we can do it artificial intelligence based help, and we can say that what could be the length of the stay of the patient in the hospital for a particular subtype of myocardial infarction versus the other one, and whether the comorbid condition are there. So all these things can help in logistics, it can help in finances, it can help in to structure how the whole expenses are. So it has got a wide range of it. Again, coming back to the point is that I would today restrict that what we have done so far in artificial intelligence in our hospital and in the field of cardiology, and specifically in Apollo. So I'm extremely excited and very happy to share with you that that is Apollo Hospital, along with Microsoft, we partnered and we developed a model called artificial intelligence based cardiovascular disease risk score. This cardiovascular disease risk score is primarily done to see what is the cardiac risk for anybody who's above 18 years to 80 years. So this cardiac risk score can be applied on any normal person, who is between 18 years to 80 years. I want to make it one thing extremely clear right at the outset, because I do not want anybody to carry a wrong information or wrong impression about it, is that we are not trying to diagnose the heart disease. We are not trying to diagnose coronary disease. We are not going to say like the way the MRIs are done or the PET scans are done or the dobutamine stress echoes are done. So it is something of that sort. Please don't think it is a diagnosing a coronary disease. In fact, in this model, most of the people who had an event of coronary disease are not really good candidates for assessing the risk score. So this risk score is for a general population, for you and me, for anybody who's in a general population. Okay. Now the question comes again that why do we require this risk scores, and is it the first time the risk score has been done? So again, I'll take you to the statistics, what exactly the current status today is. So the coronary disease, or in a very simple way, heart attacks have become literally an epidemic in our country. Although we are all worried about this pandemic, but heart attacks as such are epidemic in this country. To just give you a small statistics, that in 1990, there used to be a 2.2 million deaths. I'm talking about mortalities, 2.2 million deaths because of the heart attacks, which has risen to 4.7 millions by 2015 and 2016. So you can imagine it is just pure mortality I'm talking about, the death rate. If you see the prevalence of coronary disease, it is again very, very scary. The whole thing is, if you see in urban population, somewhere around 1.5 to 13% of the urban population is having a coronary disease. And rural population is also not much of a difference, which is varying between 2% to 9% of the total population. And snapshot survey in 2016 showed that the prevalence of coronary disease in our country is about 56 million. So 56 million people at any given time in 2016 were having a heart problem or heart disease. So that's the extent of the problem. That's the extent of the disease which we are facing every day. And I can assure you that any amount of tertiary care hospitals or any amount of cardiologists or any amount of physicians or doctors would never be able to contain the disease unless everybody understands it and we devise some methodology whereby we can probably pick up this disease at a very early stage. And maybe before the disease is manifested, what are the components required to manifest that disease? If we can figure out those and start doing something, so then only we can probably prevent this epidemic or pandemic. So this was the main driver for me way back in 2016 to start working on this particular field. We have been working for the last 5 years. And we are extremely happy. The central Microsoft national as well as their headquarters at Seattle, we all work together, and then eventually we could make a cardiac disease risk score. Again, the one point which I missed out is it the first time the risk score is there? No, there are already the risk scores are available. Okay, one of them, the most common that is Framingham's risk score. The Framingham being the very popular and it's prevalent for the biggest longitudinal study with the Framingham is there for the last 30 years, 35 years. But what is the problem in this Framingham? The problem in Framingham is this score has been devised in Western country, and we are trying to extrapolate that data on our country. That is the first thing. And secondly, the ethnic population, they have not considered. They had a very fixed 5-6 risk factors. Even if we accept all this, the most troublesome thing is most of the trials which are done in Western countries as well as in our country also, when randomized trials were done with these risk scores, the outcomes have been very unsatisfactory or less satisfactory. Outcomes were not good. So in other words, these risk scores which are available have not resulted into a significant outcome or a good outcome. So maybe there was a problem in the modeling of the risk score or whatever it may be. It could be various factors are there. So with all this background, we felt that probably the need of the hour is we should devise a risk score, which is probably not in the traditional way, but in a different way, which can help us out in identifying the vulnerable population, and probably we can start doing preventive business. So with these fundamentals, we started the journey, and we are extremely happy that after about 17 to 18 months of rigorous going through it, we started with almost like 400,000 patients. It was initially a retrospective trial. Subsequently, we made it a prospective trial. In a retrospective trial, we started with 400,000 people. And after the propensity matching and after all the filtration, finally we had a cohort of 34,000 patients, 34,000 patients cohort, which was both controls and as well as the subjects. And anyway, we don't have to go into the details of the model and other things. But the best part of it is the accuracy in a simple thing, we call it the area under curve, AUC, in machine learning language, or in simple terms to understand, is an accuracy. The accuracy of our model is 90%, whereas the accuracy of Framingham and all those models are around 45 to 47 or 48%. So the first time in the world, we came out with a risk score, which is having an accuracy of double the accuracy of the existing scores. Another thing we can say very proudly and very confident that we validated our model not only in Apollo group first initially, because we have done in 2 centers of Apollo. Subsequently, we went into national level. That means we have taken the 2 premier institutes of the country, which were external to Apollo, and they validated it. And again, their accuracies came about to 87 to 90%. Then we went internationally, and I'm very happy to say again that Maastricht, which is the leading university in Netherlands, which is one of the topmost university in Europe as far as the research papers are concerned. And when even they have validated it, and their model is still having an accuracy of 89% to 92%. So the model which we created is tested, is retested, validated nationally, internationally, and now we are trying to apply it and we are trying to roll out for everybody. Now, what do we do in this thing? What are the requirements for a common man? Okay. The best part of it is they don't have to do anything. It hardly takes less than 2 to 3 minutes. It's basically, we have taken our 21 parameters, which we call it as the features, which is again taken through a history, and there are different variables are there. That is taken, and then it is integrated in our system. We through an API, we enter it into our system, and in less than a minute or less than 2 minutes, we can get the score of that person. So what it does is, it tells the risk of that particular person at that particular moment. So it gives the 2 values. One is what is an optimal value for that person, and what is his risk score. So in other words, we can say in simple thing is, let us say my score, if I get my AICVD score done, it has come 15, and my optimal score is 11. So that means my risk is, then we give a categorization there, where whether it falls into a mild risk, moderate risk, or high risk. And depending on that, we further advise what can be done. Second best part of it is this, we can track the score. There is a feedback loop is there, and then we can track it over a period of time. That means, let us say today my score was 15, and it also gives the top 3 modifiable factors. That means what can be, let us say that suppose if I'm not doing a physical exercise, or if my blood pressure is high, which is not under control, or probably I'm having obesity or whatever it is. So 3 modifiable risk factors also is given by the machine learning, by the artificial intelligence DNN scores. And one can start working on those 3 modifiable risk factors for next 3 months to 6 months. And if a person feels that, oh, he has done a good job on this, he has worked enough on that, he can reassess again his score. And again, we can know whether his score is going up or going down. So thereby keeping a track that what exactly is happening with his physical status and health status.
We'll just look at some questions from our viewers. So does this AI risk assessment, is it something which should be, is it available to individuals to just use it, or is it only available at a doctor's consultation? Okay.
So right at the outset, this is available only at the Apollo hospitals only, okay, and in few designated centers. Okay. Eventually, of course, there will be a stage, there will be a time, but once we are rolling it out, because we are into part of the prospective trial as well. And over a period of time, yes, there will be a stage when it will be available to anybody, anyone online, and probably they can start again. It is on a cloud platform. It's on an Azure cloud platform of Microsoft, and then probably by that one can start assessing this.
Would this AI-based cardiac risk assessment also come up with recommendations on what that person should do to mitigate the risk, as in terms of any lifestyle modification or any interventions that need to be done, medications that need to be taken? So, does it go as far as making those recommendations also?
Absolutely. As I mentioned that basically, of course, this is a two-page scoring system which will be handed over to any person. And if he falls into a minimal risk or low risk, obviously, then he can walk away because then he or she doesn't have to do anything about it. But if the person is an intermediate risk or high risk, then there are definitely recommendations. First thing is, as I said, that top three modifiable risk factors will be mentioned in the report itself. So the normal layman also can know what are the three things he needs to start doing immediately. But every report, we always tell them, suggest them to go to their doctor, and the doctor can definitely, and there are further recommendations are there depending on which category he falls into, whether it's an intermediate category or high risk category. According to that, we do the appropriate tests and then we further categorize them and quantify the risk.
So, is this all done through the electronic health record of the patient, or is it after the patient's physical examination
No, that is the beauty of it, that this is not, we are not doing any clinical examination. And in fact, most of the time, only two lab reports are required. And those two lab reports are the lipids and the diabetes one. If in the last 3 months, if they have done it, it's good enough. They don't have to do anything. They can just walk in and get the report. But if it is not there, that also we are providing it immediately. There are instant machines are there, and the lipid levels as well as the sugar HbA1c can be calculated, and then we give it the report.
Was this artificial intelligence of any use during the COVID pandemic when there were severe restrictions on movement of patients and there was a lot of, it was an overwhelming situation. So at that time, what role did this AI and risk scoring play, or did it help in detecting even the COVID high risk patients?
Absolutely. Although I'm not the right person to talk about it because I will restrict myself to cardiology, but I know because I'm involved with artificial intelligence in the program as such, and it has been one of the most successful things because the COVID comorbidity, COVID morbidity, and the prolongation of hospitalization, we have used the artificial intelligence based models on that, and specifically for the COVID ones. And I'm happy to share that on academic forums, there have been the work was published even in the Nature, which is supposed to be one of the highest impact journal, the journal. In that also, the work which was done in that at Apollo on COVID has been recognized and published. So there has been a fantastic work. But again, COVID is a more of an internal medicine and the chest physician, so probably they can brief it about it. But it was extensively used during COVID times also.
So the last question is, what is the next thing for AI and cardiology? What are the next achievements, and what are the next steps, and what are the next levels of innovation that you're expecting?
Oh, I think I personally feel maybe I'm a little biased because I work so much in artificial intelligence, but I feel that sky is the limit for artificial intelligence in cardiology. Literally every sphere, every aspect of cardiology will be touched by, can be utilized by artificial intelligence. In my day-to-day practice, the simple thing is the instant restenosis after doing an angioplasty. What is an instant restenosis? We can predict right at the time of angioplasty itself by using an AI model. The other one which we are already working in our center is the detecting heart failure patients, because the burden of the disease which is going to really bother everybody, even our country as well as globally also in next 5 to 10 years, is heart failure. After heart attack, which is going to really the worry everyone is heart failures, and how to detect heart failures much more earlier than today what we are doing it, because we are not able to detect early and then we are simply treating these patients. So we are developing a robust model in heart failure as well, and AI is the base, is the core of that.
Thank you so much, Dr. Shiv Kumar, for this amazing discussion on how healthcare is transforming to help more people faster, quicker with artificial intelligence, with more efficiency and accuracy. Viewers, I hope you enjoyed this discussion and do put in your further queries and comments on our Facebook page and do subscribe to our YouTube channel to get the latest information on our trending healthcare topics. Till we meet again, stay safe and stay healthy. See you soon. Thank you and namaste.